Hello, my name is Dr. George Rogu, and I am one of the many instructors for the website called AdoptionEducationClasses.com. Today, I would like to speak to you about the parental approach to the pre-adoption medical records evaluation and the blind referral. I just got my referral package. Some parents have described this time as a moment of great joy and happiness. One mother even mentioned it as being similar to the sensation one feels when they give birth to their biological child. Then they read the medical report, worry and concern set in. A portion of the adoption stress is created because of the unknown medical history or the confusing medical history that is found on the medical reports. Parents that become educated and knowledgeable about the international adoption medicine become confident in their referral. They will be able to make an educated decision. Unfortunately, in some cases, some families decide that the referral is not for them. This moment has been described as a moment of grief and sorrow, similar to the mourning that one experiences with the death of a child. So, I find my role as an educator, a counselor, a private detective, and lastly, as a physician. Now, what is my role as an adoption medicine physician? Our role is primarily to interpret the medical records. We plot the growth parameters on the standardized CDC growth charts. We try to educate the families in regards to possible medical problems that may be found on the reports. We review video footage and pictures. We try to comment on the developmental milestones that are observed on the videotapes. We speak about facial features and the body conformation of the child. Through this, we look for identifiable medical conditions. We also try to explain the bizarre Russian diagnoses which are often found on the medical reports, and we try to dismiss them accordingly if developmental milestones are successfully completed on the video footage. Lastly, we assign a risk category to the child. Now, what does an adoption physician not do? We do not pick out children for adoption. We do not decide which child to adopt and which one not to adopt. We do not give a warranty on the child's future health. We cannot tell parents if their child will be normal. We certainly do not place children for adoption, and we are in no way involved in the adoption process. Our primary objectives are education and knowledge. We try to answer questions that parents may have, and for those that are involved in the blind referral process, we are a lifelink back to the United States. We try to provide educational support during the entire adoption travel. This way, families never feel abandoned while they are overseas. Now, in regards to the history of international adoption, in the 70s and in the 80s, many of the children were younger, infants and toddlers. They lived in small foster homes and in small orphanages. These children received limited medical care, and their medical information was scanty at best. A majority of these children came from Asian countries. In the 90s to present, after the fall of the Iron Curtain, the majority of the children are coming from the former Eastern European bloc countries. These children tend to be toddlers and older children, and sometimes sibling groups. The majority of these children have spent a good portion of their young lives living in an institutional care setting. These children come to us with an array of more complicated medical and social issues, and the medical reports that we receive are sometimes full of unintelligible neurological diagnoses that often scare the potentially adoptive parent. What are some of the reasons why children are placed for adoption? The reasons seem to be universal no matter what country the children are arriving from. The most common reason is poverty. Other reasons are single parenting, involuntary termination of the parental rights, drug and alcohol abuse, incarceration of the parents, mental deficiency, and lastly, the parental death. The health status of international adoptees are also similar depending on what country they are arriving from, and each country has its own specific nuances. Now, infections are the most common conditions that we encounter, and the reason is simple. You have a lot of little children living in a confined environment with poor hygiene. We often find parasitic infections, exposure to tuberculosis and active tuberculosis, sometimes hepatitis, and historically we found in the past cases of HIV infection. Fortunately, because of international knowledge in regards to HIV, that is no longer one of the top infections. Malnutrition and growth delays are also common. Cognitive and developmental delays. A lot of socio-affective conditions such as reactive attachment disorder, post-traumatic stress disorder. Unfortunately, we see physical and sexual abuse. The sexual abuse usually is at the hands of older institutionalized children, or sometimes the caregivers. We also find identifiable problems such as fetal alcohol syndrome, prematurity, cleft lip, cleft palate, and the reports are often full of Russian neurological terms. Now, some other conditions that we find on the medical reports are the lack of prenatal care, prematurity, syphilis and other sexually transmitted diseases, small for gestational age infants, intrauterine growth retardation, small head size or microcephaly, mild to moderate growth delays and developmental delays, and once again, the Russian neurological diagnoses. Unusual Russian diagnoses. Unfortunately, it appears on a majority of the medical reports that we evaluate. It is too often inappropriately dismissed by the untrained personnel just because it's common and just because it says so on the internet. It should only be dismissed if and only if the appropriate milestones are visualized on the videotape, or if the milestones are accurately documented on the medical report. Now, I'd like to speak to you briefly about my first international adoption evaluation. My first evaluation was about a little boy, Andre, and he was approximately 6 months of age. And one evening, Andre's mother appears in my office, very, very happy with her videotape, her medical records, and some pictures, and had asked me if I would look at it and give a professional opinion whether to adopt or not adopt the child. Now, I briefly looked at the report. On the report, I found a number of diagnoses, for example, the perinatal encephalopathy, anoxic cerebral ischemia. Now, I was thinking, boy, this sounds very, very similar if I was to translate it into English as cerebral palsy. I was devastated. I didn't know how I was going to tell this happy adoptive mother that, maybe her child has cerebral palsy. Well, in order to buy some time, I decided to look at the videotape. And on the videotape, I saw Andre. Yes, he had some mild delays, but he was 6 months. He was sitting without support. He was rolling over. He was supporting his chest, pushing up, interacting, smiling. And then I thought, boy, 1 and 1 does not equal 2 in this case. And that's how I decided to go into international adoption medicine. Well, Andre now is 8 years old. He's an honor student in his school. He's doing very, very well in his classes, playful, happy. I am very happy that Andre's mother had adopted him. Now, some examples of these peculiar Russian diagnoses, I'll say, are perinatal encephalopathy, spastic tetraparesis, muscular dystonia, vegetovisceral syndrome, pyramidal insufficiency. My favorite is minimal brain dysfunction, abnormal chordae in the heart, intestinal dysbacteriosis, and the list goes on and on and on. Now, I could understand why some parents, when they see the reports, are shocked, and they just do not know what to make of this information. There are now some myths out there on the internet about the medical terminology in regards to the Russian nomenclature. Now, myth number one says that they give these diagnoses to these infants in order to increase the orphanage funds. That is not true. And myth number two, it is used to facilitate adoption. In other words, they give them a false diagnosis so they can be placed for adoption because normal children cannot be placed for adoption, normal healthy children. The truth of the matter is that the Russian physicians practice a little bit differently than we do here in the United States. They believe in what they document, and they do believe that infants and young toddlers are neurologically immature. And because of this immaturity, that is why they give these diagnoses. They consider the infants to be defective, and over time, as they attain their developmental milestones, then these diagnoses are removed. Now, the most common diagnoses that we often find, as I alluded to earlier, is perinatal encephalopathy. If you were to look this up in the medical dictionary, it would say something about cerebral palsy, or it's an insult to the central nervous system during the perinatal period. Now, the most common diagnoses that we often find on the medical reports are perinatal encephalopathy. If you were to look at this word in the medical dictionary, one would find a description similar to cerebral palsy, which is basically a devastated child. And it occurs secondary to an insult to the central nervous system during the perinatal period. Now, in Russia, this diagnosis is given when high-risk factors are present. And these high-risk factors can be on the behalf of the mother or the infant. Yes, these high-risk factors may potentially lead to a poor neurological outcome in the future, but it does not necessarily mean that each and every child will have a poor neurological outcome. After 1 year of age, when the developmental milestones are attained, these diagnoses are removed. Now, I'd like to speak to you about a couple of examples of why, from the mother's medical history, one would get a diagnosis of perinatal encephalopathy. The first is the lack of a known medical history. The second is drug and alcohol or cigarette use, lack of prenatal care, if the mother had anemias or a chronic medical condition, if the mother had previous miscarriages, abortions, or premature deliveries, if the mother was a young mother, if the mother was an older mother, if she had any infections, if there was a poor social situation, if it was a complicated or difficult delivery, or if there was any problems with the placenta. Any of these high-risk conditions can certainly give you this diagnosis, and I believe this is the reason why it's so common. Because you often have no medical history, you often have no prenatal care, and you often have a poor social situation on the mother's behalf. Now, in regard to the infant can trigger a diagnosis in Russia of perinatal encephalopathy by the simple fact of having a low APGAR score. If there's any abnormal muscle tone or reflexes, if the child had seizures, irritability or depression, poor feeding, poor suck, if there are any abnormal congenital problems, genetic conditions, if there are any abnormal ultrasounds of the brain or other body parts, if there are any intrauterine or perinatal infections, if the child was premature, if there's abnormal growth or any abnormal test. So unless the mother had prenatal care and the child came out perfect, the children always get this diagnosis. Now, I spoke to you earlier about a case of perinatal encephalopathy where the diagnosis was dismissed, and now I'd like to speak to you about a case where it actually meant something. Victoria was a 4-year-old who was an ex-premature infant of approximately 29 weeks gestation, had a very low APGAR score, the mother had no prenatal care, and the child at birth required some form of resuscitative measures and was intubated for a couple of weeks. The child did well and over the years had been attaining a majority of developmental milestones. Now, of course, this diagnosis is on the report. Now, in order to exclude this diagnosis as being significant, we have to see a child that has normal developmental milestones. Now, Victoria is 4 years old, so you would expect Victoria to be running around, interacting, happy, and in the video report we do see Victoria doing these things, but we only see her upper part of her body doing it. Then, when we see Victoria walking, we see Victoria walking with a little bit of a limp, and we see Victoria trying to ride a little scooter, a little tricycle, and she had a very, very difficult time lifting that right leg and getting it over the seat. Now, this would lead you to believe that there was some kind of a neurological insult. She certainly did have some of the criteria in order to get this, that caused some kind of trauma to the brain, anoxic trauma to the brain, that affected the lower extremities. The upper extremities were fine, her intellectual capabilities were perfect, but she had some defects in the lower extremities. This is your case that the perinatal encephalopathy, along with the history and the video, actually means something. Victoria indeed had mild cerebral palsy. She wasn't one of those devastated children that are condemned to a wheelchair for the rest of their lives, but she will be into special needs, and the parents were aware of this. Now, some other diagnoses that we find on the Russian medical reports, as I alluded to earlier, I'd like to speak to you briefly about minimal brain dysfunction. Minimal brain dysfunction sounds like a serious problem. Now, it's used to describe a transient neurological condition such as an abnormality in the reflexes or soft neurological signs such as hyperactivity or short attention span. It may mean what we diagnose today here in the U.S. as ADHD or attention deficit hyperactivity disorder. This is important because if one finds this diagnosis on the medical report and one observes on the pictures or on the video some of the stigmata for fetal alcohol syndrome, then maybe the diagnosis makes sense. Now, another diagnosis that I often see on the medical reports is minimal brain dysfunction. This diagnosis is used to describe a transient neurological condition such as an abnormality in the reflexes or soft neurological signs such as hyperactivity or short attention span. It means what we diagnose here in the United States as ADHD or attention deficit hyperactivity disorder. Now, this is an important diagnosis when discovered on a report because it depends in what context this diagnosis appears. If we see a child that on the video report has some of the characteristics for fetal alcohol syndrome, such as a thin upper lip, a absent philtrum, the indentation above the upper lip, a flat face, a small head size, and we have the diagnosis of minimal brain dysfunction, then the risk for actually having the diagnosis of fetal alcohol syndrome is much higher. Now, minimal brain dysfunction by itself basically means ADHD. And you can find out if the child truly has this diagnosis by observing him in a videotape. Many children in videotapes are quiet, they're collected, they really do not want to have anything to do with what's going on. Sometimes they're very sad. But I've seen videotapes where the children are very, very busy, hyperactive. When you notice that they have bruises on their forehead, on their chins, if they have lacerations on their face and they have the diagnosis of minimal brain dysfunction, then the probability of ADHD is very high. Now, in order to evaluate videotapes and records and pictures, there are different types of evaluations out there. The most common type of evaluation is the pre-adoption evaluation, and what is becoming more common these days is the blind referral. Each one has advantages and it has disadvantages. Now, I'd like to speak to you first about the pre-adoption evaluation. This is when we receive medical records, growth parameters, and video records and pictures. The blind referrals basically have nothing. The parents are told to travel overseas and basically choose their child. Sometimes they have a few lines. Many times they have just a sex and an age. Now, the pre-adoption evaluations usually come from Russia, China, Korea, Kazakhstan, Guatemala, India. Each country has its own specific criteria and problems associated with it. The best scenario is when we receive a videotape, medical reports, plenty of growth parameters, and pictures, but that does not always happen. Now, some of the advantages of having a pre-adoption evaluation performed before you travel to pick up your child is the mere fact that you're making your decision before you go. You have plenty of time to consult with an adoption professional. You have time to read and become educated about the conditions on your report. You have time to speak with other families that were in your situation before. You can request more information from your agency if it's required. And basically, you know what you're getting, or at least you have an idea of what you're getting before you travel. Now, with this come some disadvantages also. Some of the disadvantages are that the medical reports can be misleading. A lot of the growth parameters are inaccurate. Sometimes picture quality and video footage is very poor. There are plenty of translation inaccuracies. There's missing information and basically just careless preparation of the documents. Now, the blind referral evaluation basically can be performed from any country that has broadband internet access. It can be from Russia, China, Korea, Kazakhstan, India, anywhere. Now, I'd like to speak to you firstly about the disadvantages of the blind referral. The disadvantages are before you travel, you do not know anything about the health status, the sex, or the age of the child. By the time you travel, the child may no longer be available. You may travel far and not even find a child to adopt. The decision often must be made quickly. Sometimes the availability of a consultant physician is not possible. Family and other types of supportive services are not available, and the language barriers. Now, The blind referral evaluation has taken these disadvantages and turned them into advantages. The adoption doctor's blind referral evaluation is considered a lifelink to the United States. It is a complete support service for families during their adoption travel. Through the blind referral evaluation, we teach families how to become a physician. We teach them to collect the medical data, what medical data is important. We teach them to prepare a video and pictures. We are in constant communication with families via the internet, using email and instant messaging. We've developed a system where families can upload video footage directly to a website. Pictures can be uploaded through email or directly to a website. And while the families are there, educational support can be provided with a telephone conference about their referral or ongoing communications through the instant messaging and email. Now, in order to prepare for the blind referral evaluation, families need to have a crash course in medical data collection. Medical data can be obtained from any person that is involved in the care of the child. It can be from the medical director, nurses, foster parents, individual people that just care for the children, and very, very important during the evaluation, the personal interpretation of the adoptive parents is vital to the evaluation process. Now, in order for a parent to become an adoption doctor, they need to observe the child in a familiar environment. They need to perform a crude developmental exam. They need to collect the important medical data. They need to prepare daily video footage of the child. And it's very interesting because when a parent goes to see a potentially adopted child, that child is scared, timid, sad. One would want the child to come running to the new mother, but these children usually don't. They're sad, they're aloof, they really do not do much. And I've observed many times on that first video, the child is like a washcloth. The second day, when the mother goes back, the child is a little bit more interactive. By the third day, the child may vocalize a little bit. By the fourth day, there may be even a little smile. So daily video clips of the child is very, very important. We need to examine the child's energy level and social interactions with other people in the room. And we need to try to look for any of the institutional behaviors such as rocking, banging. Now, the question, what data is important to collect? Obviously, the more information you can collect, the better the evaluation. Now, in order to better prepare families in data collection, I tried to prepare a list of punch questions that they can ask. Now, in order to start, we find out, was it a home birth or was it a hospital birth? How many pregnancies did the mother have? Were there any birth issues? Were there any health issues during the pregnancy? What was the child's APGAR score at birth? A low APGAR score would mean that something serious happened during the delivery. An APGAR score of 9 meant that the child was born, was pink, cried, and went to the mother. What type of delivery was it? Was it a cesarean section or was it a vaginal delivery? We would like to know what was the child's actual birth weight, height, and head circumference. And what were the circumstances behind the abandonment? Did the child go home with the mother for a while and live with the mother and then the mother decided to abandon the child? Or was the child born and placed in the hospital for the first couple of weeks and then transferred to the baby homes? Other medical data of importance is the family history. How old was the mother? How old was the father? But that's usually not information that we can easily obtain. Are there any other siblings in the home or in the orphanage? Some social information is very important, such as, did the mother abuse drugs during the pregnancy or alcohol? Growth parameters for the child are also very important. The head, the height, and the weight at 2 months, 4 months, 6 months, 8 months, 10 months, whatever growth parameters we have, it is great because we can plot these growth parameters on the growth charts and see how the child is progressing. Unfortunately, children that live in orphanages tend to have growth delays and they fall below the growth chart. There are some studies out there that state for every 3 to 4 months that a child lives in an orphanage environment, there is a 1-month delay in the growth parameters. Now, physical examinations that the child has had in the past would be of importance. The overall health issues of the child while they are in the orphanage is also important. Did the child have asthma, anemia, vomiting, diarrhea, allergies, or any heart murmurs, urinary tract infections, any chronic medical issues? The hospitalization history is also important. A child that had been hospitalized numerous times for seizure disorder generally have a higher risk in adoption. Were there any medical interventions while the child was in the orphanage? Was there any surgery? Did the child receive a blood transfusion? Was the child admitted to the hospital and received IV antibiotics for whatever reason? And what other diagnoses are given to the child? Now, of importance is also some medical laboratory data. I often find on a lot of the reports a head ultrasound and an abdominal ultrasound. While we do not do these tests routinely on every single child, it does give us a little bit of information when it is normal. A normal abdominal ultrasound basically means that the internal organ structures of the child are anatomically correct. A normal head sonogram performed basically means that the brain structures are intact. There's no significant signs of bleeding or any other collection of fluid in the brain or so forth, which would make it a higher risk if there was. So I like negative results. The positive ones are always a situation because now we have to explain them. Now the most important laboratory investigation that I insist upon is a test for HIV, hepatitis B, hepatitis C, and syphilis. Each and every child should have a negative result. A negative result is very good because at least we know that the child probably does not have any of these problems. I consider these tests screening tools only. The blood tests need to be retaken post-adoption, and only then can a negative result be confirmed. I have seen plenty of cases where the HIV test and the syphilis test were negative, and post-adoption they were still negative. But I had one sad case where the pre-adoption evaluation was not performed because it was determined that the country that was sending this child was a country that generally sends only healthy infants. So the mother felt that a consultation with an adoption professional was not needed. Post-adoption, the laboratory investigations proved to have a positive HIV result. This was a very sad case because the mother had already bonded to this child. The mother now had an HIV positive infant and has a life-altering diagnosis. Now, if she only knew beforehand, she could have made an educated decision. Now, she was forced to accept this medical condition. Now, Other medical data that is of importance is a developmental commentary. Parents, when they become the adoption professional, are able to perform a crude developmental evaluation, which can be shown on a videotape. We like to see families evaluate these children by having them perform gross and fine motor movements that are appropriate for the child's developmental age. If the child is 4 months of age, the child should be sitting with support and rolling over. If the child is 6 months of age, the child should be sitting without support, tripoding, holding the head, putting the feet in the mouth. The child is 8 months of age, the child should be creeping and crawling. 9, 10 months of age, pulling to stand. 12 months of age, standing alone. Some developmental commentaries by physicians and nurses are of vital importance also. Now, immunization status, that is always a controversial situation. It's controversial because nobody knows really, in regards to vaccines, how well these vaccines were taken care of before they were administered to the child. Vaccines need to be stored in a certain temperature, and that temperature needs to be recorded daily. If there's a power outage or the refrigerator defrosts, the vaccines can become spoiled. Now, in a rural part of a country that has no vaccination, maybe they will give the vaccines that have been altered. Growth parameters are also very, very important. You'll see on this growth chart the classic growth chart that we see on a lot of the pre-adoption evaluations. The children are very small, usually below the growth charts. It is well known that children grow poorly in an orphanage, and there is a 1 month in growth delay for every 3 to 4 months that the child lives in an orphanage. And this is called institutional growth delay. And this generally happens because lack of social interaction, lack of nutrition and calories. The children tend to be depressed and sad, and depression does lead to a poor appetite. Sometimes we have errors in measurements. Sometimes we have failure to thrive or failure to grow because the child has an underlying chronic medical condition, such as an intestinal parasite that does not let the child absorb the nutritional calories that are required to grow. Sometimes the children are given medication and sedatives in order to keep them silent and quiet and behaved, and sedatives also inhibit appetite and do not allow the child to eat and grow well. And just overall isolation from the world tends to make children not grow well. Now, this growth chart is a growth chart of a child before being adopted and then afterwards. This is the type of a growth chart that I always see. It's a skyrocketing increase, and it's simple. There's sufficient food and feedings at home. There's somebody to care and love for the child. Medical problems are resolved. Depression is resolved if any sedatives that were given are no longer given, and malnutrition and other types of deficiencies are corrected. Now, the preparation of the video record is of vital importance in the pre-adoption evaluation or the blind referral. Parents need to understand that short sequential clips of 3 to 5 minutes are more important than one very, very long clip. When preparing the video, you should stay at a stable distance of about 3 feet from the child. Do not zoom in and zoom out, zoom in and zoom out. Set up the camera and just leave it there. Try to get a close-up of the child's face. This way we can look for any of the facial stigmata for fetal alcohol syndrome, basically the thin upper lip and the indentation of the upper lip called the philtrum, and get a picture in the profile so we can see if the child has a flat head. Try not to stand and film downwards on the child. Try to stay at eye level with the child. Have the child perform some of those gross and fine motor activities that we described earlier. And also try to get a bearing on the child's psychosocial and language abilities, which unfortunately may be non-existent at the time that the video is taken. Have one parent try to interact with the child, and when you prepare the video footage, do not prepare it in a place where the environment is very, very crowded, full of noise, and full of commotion. These children do not do well in these types of environments. Pictures are also helpful in the evaluation process because a picture can give us insight as to any possible genetic anomalies that may be found in this child. For example, Down syndrome, clearly seen on a picture. We have some information through a picture about the child's skull shape, about the child's ear abnormalities, if the child has cross-eyedness or lazy eyes, if there are any stigmata for fetal alcohol syndrome. Pictures help us with signs of abuse or other types of skin rashes like Mongolian spots. A picture can help us to understand the child's overall nutritional status. And a picture helps us to look at the child's body habitus. A child that looks sickly and emaciated may be suffering from a chronic disease. Now, every picture does tell a story. Looking at these pictures, we have children with correctable medical conditions. We have a little girl that has a cleft lip as an infant that was adopted and had her cleft lip repaired. You can see before and after pictures of this beautiful little girl. In the middle bottom, we have a child with the bowed legs, which are signs of rickets. Upper right hand corner, we have a child that you can clearly see has one of the eyes turning inwards. This child has a diagnosis of lazy eye or strabismus. Now, the bottom right hand corner, we have a little boy that also has a lazy eye, and you can see on the right side of his mouth he has a laceration. Now, looking at this child and looking at the medical report, this child had a diagnosis of minimal brain dysfunction. Now, with the child that has a laceration in the mouth, minimal brain dysfunction, and you look at the video footage and the child is very busy, running all over the place, this child probably has ADHD features. Other medical and genetic problems that can be found through pictures and video are, I mentioned earlier, Down syndrome, fetal alcohol syndrome. An emaciated child, like the child in the upper right-hand corner, that's your clear-cut case. You can see how sickly looking this child is. That's your clear-cut case of full-blown AIDS. The child in the left lower-hand corner is a child that's very thin. You see that there's no muscle mass in the legs and in the arms. That's your malnourished child. Malnutrition can be from chronic illness, parasitic infection, or just poor caloric intake. The right lower hand corner picture is a picture of a premature infant. Now, becoming the doctor, collecting the data, getting the video and pictures prepared, that's the easy part. Sometimes the most complicated part is getting all this data back to me here in the United States. That can be a tricky process. Now, it is only challenging if you are adopting from a part of a country that has no internet access. But now, day and age, most hotels have some type of broadband internet access, at least in their lobbies. In Europe, it's common to have internet cafes in major cities. Sometimes you find broadband access at airports. And if you have broadband internet, you can get all this data back to the United States to an adoption physician. The digital cameras that we have these days are good to take your pictures, and you can also shoot video. One of those little 1 gig SD cards can hold up to 30 minutes of video footage. That is more than enough video footage to evaluate a child. If you're using just simple email, you will have to use short sequential clips because the email servers will not allow a very large file because it thinks it's spam. Now, with the advent of different types of video hosting websites such as YouTube and the website hosting server that we have on Adoption Doctors, you can upload your video footage directly to the websites for the physician to evaluate back home. Pictures can be sent through Shutterfly or OldPhoto for the physician to evaluate, or straight email. For those that are tech savvy, you can video conference with your physician. And for those people that have no possibility of getting any of this data home, just recording your videotape and bringing it to the United States afterwards is more than adequate. You can do the evaluation later. Now, the importance of having a pre-adoption evaluation is, one of the important things is to be able to understand the case and be educated in the fact that maybe some more information is required. A physician can help you with that. A physician can tell you if you have a missing HIV test, you must get that result. If the growth parameters are strange, you can ask for more growth parameters. If the developmental milestones are a little bit delayed or peculiar, maybe another videotape a month later is in order. If there were any blood tests or other types of ancillary tests performed, we can ask for those results or request that these tests be performed. If the child has on the report a diagnosis of like a hernia, then maybe we can request that a surgeon take a look at the child and let us know if the hernia truly does exist. Often, a common thing that we have are in the pre-adoption evaluations, especially, are bad pictures. Somebody took a picture of the child at standing up level, looking down on the child, and we have an obstruction of the upper lip causing a thin upper lip and a missing philtrum. Immediately we start wondering about fetal alcohol syndrome. But if we have 5 pictures and only 1 picture is bad and 4 are good, then maybe the child does not have any issues. But sometimes the pictures are all bad and we may require more pictures. Now, international adoption is indeed a leap of faith, but parents should become empowered with education and knowledge in order to make this a calculated leap of faith. Now, the most important part of the pre-adoption evaluation or the blind referral evaluation is that telephone consult with your physician. During the process, a complete report is prepared for each case, and the terminology is explained in layman terms, simple to understand. What we like to do is we like to give the parents the report ahead of time for them to read and digest and prepare any questions that they may have. After the parents evaluate the report, that telephone consultation is the time when both parents can speak with the family in a calm, collected manner and just go over the report and brainstorm it together. Their questions can be placed to the physician and any concerns can be alleviated at that time. What we also like to do is to go over some of the immediate post-adoption concerns that may be encountered when the child arrives home, and we like to give the parents a little bit of advice on some travel health tips. Another important feature is the risk assessment. Now, while every single adoption in itself is a risk, there's different grades of risk. There's average to severe risk. An average risk is basically your child that is placed for adoption that has no underlying medical conditions, developmental milestones are on target, video footage is great, pictures have no features that would make one worry about fetal alcohol syndrome. Severe risk is when there are 3 or more problems that are found on the report that need to be entertained. Usually the life-altering conditions, such as seizures, severe delays, cerebral palsy and such. Now, in the pre-adoption evaluation, a post-adoption medical plan is also of importance. This is important because sometimes follow-up is not always possible with a pediatrician, let alone an adoption pediatrician. The follow-up plan can be prepared for the family practitioner to evaluate. When they evaluate the child, we can give them a guide as to what they need to do. If there are any specialty referrals that need to be performed, we recommend what standardized laboratory screening needs to be performed. If there are any questionable image studies that need to be performed, we try to guide the family and the physician as to what vaccination protocol should be used. Should we restart the vaccines, or should we just obtain titers and continue where we left off? And a recommendation for early intervention is always important. Now, as I mentioned earlier, the common post-arrival issues that are often encountered are feeding difficulties. These little children often become preoccupied with food. The availability of food is a concern to them because all of a sudden they have food, yet they don't know if that supply is going to disappear. So they just keep eating and eating and eating, and they're like bottomless pits. They also have an issue with the consistency of the food, because in the orphanage, many of these children are given food that is mashed in order to help prevent choking. They have a difficult time eating foods that are of a more harder consistency. So be careful with that. Sleep disorders are also problems that we often experience post-adoption. Some of these children find that sleep is a terrible time. And the reason is these children are stressed. All of a sudden, they're sleeping in a room by themselves, where in the past they lived in a room with 10 other children. They've never been alone in a room. They also have issues with, they're afraid to go to sleep because when they wake up, maybe mommy and daddy are no longer there. It's all psychological, even though they're small. Sometimes there's emotional decompensation when the child is faced with a past stressful event. We often find self-stimulating behaviors such as headbanging, rocking, flipping over. We also have the indiscriminate friendliness that's often described by some parents, where the child will latch on to anybody that gives this child some type of attention. Some children have a sensitivity to touch, light, and sound. Now, in order to ease the transition, it's best to have the child in a highly structured environment. It's best to maximize the parent-child interaction. It is best to limit contact with outside family members and avoid overstimulation of the child. Try to tolerate any bizarre behaviors that the child exhibits. Now, the post-adoption evaluation visit is generally performed 2 weeks post-arrival. If the child is urgently ill immediately, you should see your pediatrician earlier. This time is required in order to have the child live with the parents, and the parents need to observe the child for a certain amount of time. We do not need to stress out these children with an unnecessary visit to the physician's office, which is often attributed with a painful experience and traumatizing experience. Families need to get to know each other, but you should always have a physician available in case problems do occur. Now, the take-home message that I'd like to leave with you is, children grow poorly in orphanages due to neglect and isolation. The severity of the medical condition is directly proportional to however long the child lived in an institutional care environment. Growth dramatically improves post-adoption, and there are many sad personal stories out there on the internet especially, but there are also many more successful cases. Now, I would like to leave you with some final thoughts on international adoption. 1. Many diagnoses on the reports are not confirmed when they are evaluated in the United States. Developmental delays are indeed common, but children usually respond very well to early intervention services. There's quick catch-up growth on the growth parameters. Extra immunizations will not really hurt any child. And a post-adoption visit, developmental test, and medical screening is very, very important. In our own practice, we have many children adopted from Romania, Russia, China, South America, Moldova, Korea, and they are doing very, very well. Now, please visit us online at adoptiondoctors.com in order to become educated about international adoption medicine. We are the go-to place for international adoption education. Now, please proceed to the next segment of the class where you will take a short test, and then after that, a certificate of completion will be provided to you that you can submit to your agency. Thank you very much.